Good morning, all. Today's our topic is the drug for the bronchial asthma, and now the pharmacological effect on the different system. Now here we are discussing on effect on the CVS. Methyl uh, methylxanthines directly stimulated the heart and the increase of force of the myocardial contraction. They tend to increase heart rate by the cardiac action, but decrease it by causing vagal stimulation. A net effect is variable, and tachycardia is more common with the theophylline. Now the methyl xanthines, especially theophyllines, directs systemic blood vessels and including coronaries. By reduction, peripheral resistance is reduced. Here the effect on the blood pressure is variable and unpredictable. Vasomotor center and direct cardiac stimulation tend to raise blood pressure. Vagal stimulation and direct vasodilatation tends to lower blood pressure. Usually a rise in systolic and fall in diastolic blood pressure is observed. Now effect on the smooth muscle. All smooth muscles are relaxed. Most prominent effect is exerted on bronchi and especially in asthma. The theophylline is more potent than caffeine. Now, effect on the kidney. Methylxanthine are mild diuretics, act by inhibiting tubular reabsorption of the sodium and water as well as increase renal blood flow. Here the effect on the skeletal muscle. Caffeine enhancing contractile power of the skeletal muscle at high concentration. It increase release of the calcium ion for sarcoplasmic reticulum by direct action. In addition, caffeine facilitates neuromuscular transmissions by increasing acetylcholine release. Now, effect on the stomach. Methylxanthine enhance secretion of the acid and pepsin in stomach and even on perinatal injections. Now, effect on metabolism. Caffeine and to a smaller extent theophylline increase BAMR and plasma-free fatty acid levels are rises and rise of the undergrowth catecholamines and appears to the partly responsible for this effect. Mast cell and inflammatory cells. Theophylline decrease release of the histamine and other mediated from mast cell and activated inflammatory cells. Now, mechanism of action. Three distinct cellular action of the methylxanthines have been defined. Release of the calcium ion from the sarcoplasmic reticulum, especially in the skeletal and cardiac muscle, and inhibiting of phosphodiesterase PDE, which uh, degrades cyclic nucleotides in intracellular. Here the giving the effect of the ATP2 or GTP2, CMPA and GMPA and 5-AMPA or GMPA. The concentration of the cyclic nucleotides is increased and bronchodilator, cardiac stimulations and vasodilatation occur when CAMP level rises in the concerned cell. Now, block of adenosine receptors. Adenosine acts as a local mediators in CNS, CVS and other organs and contracts smooth muscles, especially bronchial, dilates and cerebral blood vessels, depresses cardiac pacemaker and inhibits gastric secretion. Action A is exerted only and concentration much higher than the therapeutic plasma concentration. B is an action. C is an exerted at the concentration in the therapeutic range on appear to contribution to the bronchodilation. Now the theophylline pharmacokinetics. Theophylline is a well absorbed orally, rectal absorption for suppository is erratic. It is a distribution in all tissue, process, placenta, and in the secreted in milk. And here the adverse effect. Theophylline has a narrow margin of the safety doses. Depends toxicity starts from the upper part of the therapeutic concentration range, and adverse effect is primarily referable to the GIT, CNS, and CVS. And headache, nervousness, and nausea are early symptoms, and children are more liable to CNS toxicity. Here the interactions. Agent which enhance theophylline metabolism primarily by the including CYP1A2 lower its plasma level dose has to be increased by the factor given in the parenthesis, and smoking, phenethylamines, and rifampicin, phenobarbitons, and charcoals, boiled meat meal. And drugs which inhibits theophylline metabolism and increase its plasma level, that erythromycin and ciprofloxacin, cimetidine, and oral contraceptives, allopurinol. Those should be reduced to two-thirds. Theophylline enhance the effect of the furosemide and mimetics and digitalis oral anticoagulants and hypoglycemic. Theophylline decrease the effect of the phenylketones and lithium. Aminophenylline injections should not be mixed in the same infusion bottle syringe without ascorbic acid and chlorpromazine and promethazine and morphine, pethidine, and phenytoin. Here the properties of the dosage. Theophylline poorly water soluble, contains by the injected 100 to 300 TDS 15 mg per kg per day. Here the aminophenylline water soluble can be injected IV but not IM, or this is highly irritation 250 to 500 mg orally, or slow IV injections in children. Here the hydroxythione theophylline water soluble can be injected IV and IM. Less irritant 250 mg orally, IM or IV. Choline theophyllinate 250 to 500 mg orally, and theophylline endothelate at piperazine 250 to 500 mg orally, and doxophylline, a long-acting oral methylxanthine, has that is a climate not to interfere with sleep or stimulating gastric secretion, and doses 400 OD or BD on children, 12 mg per kg per day. Uses: bronchial asthma, COPD. Theophylline benefits by the causing bronchodilation as well as by decreasing release of the inflammation mediated, promoting eosinophil apoptosis and improved mucociliary clearance and stimulations of the respiratory driver, and by augmenting diaphragmatic contractility. Here the second drug is apnea in premature infants. Theophylline reduce the frequency and duration of the episodes of apnea that occurs in some uh, preterm infants in the first few weeks of life, and closely monitored oral or IV treatment is employed for 1 to 3 weeks. Caffeine is uh, equally effective. Anticholinergic atropine drugs causes bronchodilatations by blocking M2 receptors mediated cholinergic concentration contractor tone. ACT primarily is large airways which received vagal uh, innervations, and however the recent evidence points to presence of M2 receptors or peripheral bronchial muscular as well. Here the leukotrienes and antagonists. Since it was realized was crystalline leukotrienes and important mediators of the bronchial asthma. Efforts were made to develop their antagonists and synthesize inhibitors to cyst leukotrienes receptor agonist. Now, Monteleucates and Jeffrey Leucates both have similar action and clinical utility. Uh, they uh, comparatively agonists and cyst LTE1 receptors mediated bronchoconstrictions and airway muscle secretion, increase vascular permeability and recruitment of the eosinophils and bronchodilation, and reduce sputum eosinophils count, and suppression of the bronchial inflammation and mucus and hyperreactivity are noted in asthma patient.